I think Dr. Varnagy takes these responsibilities very, very seriously. As you can see, he didn't choose a very easy topic. He chose a topic of graft infection and sepsis, something that anyone who's had this experience would hang his head low and say, oh, gee, I hope I didn't cause that, or if I did, now I have a really big problem on my hands. Dr. Varnagy has a celebrated history and past. Of recent, he was trained in New Jersey at the University of Medicine and Dentistry of New Jersey and other distinct universities. So without further ado, it is my great honor and great pleasure to introduce Dr. David Varnagy, who will talk today about graft infections. David.
Efharistopoli. Thank you. Thank you so much, Dr. Marouris. So today I want to talk about one of our nightmares in vascular surgery. This is, as Dr. Marouris says, is the nightmare, takes our sleep, hours, life, coronaries, all the sphincters tight when this happen, is vascular graft infections. Incidence of vascular graft infection is going down. You know, we have better antibiotic prophylaxis. We are doing better for the patient. We have better products. The packaging system for our devices is improved. There is less chance of infection, bacterial colonization. But it's definitely present. We still see it, and more in a place like this. Usually we delay the diagnosis of graft infection, and many times it becomes catastrophic. You know, they bleed, they thrombose, there is loss of the end organ tissue. So it's definitely a problem for the vascular surgeons and for the medical team. So in regards to this topic, I have nothing to disclose, but I participate in other trials and companies, but not for this topic. So incidence is around 0.2% to 5% across all the vascular beds. As we go from intracavitary to extracavitary, it becomes more frequent, meaning that inside the chest is less frequent than in the groin or in the legs. We can see that in this slide presentation, descending aorta, aortoiliacs are lower compared to a Fem-pop bypass or an AK Fem-bypass, where the amount of graft and tunneling superficial in the skin is very significant. Once we declare a patient with a graft infection, the complications are almost always present. There is a mortality of 1 to 6%, and there is some limb loss of around 5 to 25%, could be partial limb loss, or could be complete limb loss. When we are talking about supraaortic vessels, we add strokes. Many people have tried to classify graft infections. It's completely arbitrary. So in the books, we decided, or the previous vascular surgeons decided, that if it's less than 4 months, we call it early graft infection. If it's more than 4 months, it's a late graft infection. Then Dr. Etiology, who was a very well-known vascular surgeon in the Detroit area, provided us with another classification that was 1, 2, and 3, depending on the extension of the infection at the level of the skin, if it's cellulitis, if sub-Q, or the graft is involved. Dr. Bunt, in the late 90s, provided us with another classification, but it's absolutely arbitrary. He just put numbers and names to different areas without meaning that there is a change in the severity. For example, P3 is an infection of a patch, and a P0 is in a cavitary graft, but there is no difference in terms of complication rates. There is no correlation or prognosis based to that. So the etiology is based on where the graft is placed, but there is believed there is a perioperative contamination, bacteremia, mechanical erosion, involvement by contiguous infection process. Then in our vascular patients, it's very frequent. We have patients with wounds, with gangrene, and those lymphatic tissues can progress into the leg and the groin, for example, or even bacteremia. And on top of that, our patients are considered, all of them, immunosuppressed by definition, as they have peripheral vascular disease, but they have also diabetes, hypertension, and many other conditions. So the risk factors for our patients to suffer of a graft infection is a poor sterile technique, emergency surgery, prolonged OR time, re-intervention. There is a belief that there is colonies of bacteria in the incisions that may not progress deep into the graft, distal infection, wound complications. If it's related to the host, it's malnutrition, malignancy, immunodeficiency, diabetes, renal failure, and autoimmune disease. So when you see the risk factors, it's basically a miracle that we don't see more of these graft infections in our environment. A few years ago, there was a study where they tried to do a determination. It was a difference between the surgical technique, basically, between an open AAAs and endovascular AAAs. It was 13,000 patients, almost 14,000 patients. Only 61 came with a graft infection in the aorta. They were divided between open and EVAR. There was no difference between the technique for implantation of the graft, but what called the attention of the study is that no matter which technique you use, if the patient has a pneumonia, a UTI, or a wound infection, the graft infection complication increase. So once the process starts and there is a foreign body, and this has been shown in the 50s, when there was multiple studies in the lab that shows that only presence of a graft material increases chance of infection, and that if you increase the amount of graft, there is more chance of infection. It has been shown in the past. So in this study that was done in 1953, what they used, it was silk. They used single braided silk and multi. So the single braided silk has less chance of infection than multi. And from there, many other studies came out and provided us with that information. So for the bacteria to enter or colonize or be in our graft, a couple of things have to happen. Number one has to be adhesion. The bacteria has to adhere to the grafts one way or another. Once it's adhere, it produces a biofilm. The biofilm let the bacteria grow. Once the bacteria is there, the host defense forces come. So there is chemotaxis, there is complement activation, there is an inflammatory process, there is fluid build out, and once the fluid build up and the inflammatory process starts, there is a delay of the wound healing, and then the infection process starts. That's the reason that we are very careful with our incisions, and nowadays we try to use devices to avoid fluid accumulation underneath the skin to avoid this process. We also learned that early graft infections are produced by more virulent bacteria. Less virulent bacteria are seen in chronic infections. Also, the most virulent bacteria are more superficial to the skin and superficial graft than in deep graft. So we have the most common bacteria in this slide, Staph aureus in early graft infection. We see them in carotids, Fem-pop, some thoracic aorta. Epidermidis, we see it. Strep epidermidis, we see more in the delay phase of the graft infection, aortofemoral, thoracic, E. coli when there is graft enteric disruption, Pseudomonas, Klebsiella, and Enterobacter. Prevention is what we do every day. Avoid the prolonged perioperative intrahospital course. So that's the reason the vascular surgeons don't like to bring the patient a week before the operation, keep him for 2 weeks and send them out. So in general basis, we try to be very brief in our admissions, admit them the same day with day before, give him the antiseptic shower scrub, do the operation in the shortest period of time that we can, and send them home as fast as we can to avoid intrahospital infections. We try to control or remove the remote infections, so many of us will send the patients to the podiatrist if we have, or the hand surgeon if we have an upper extremity, lower extremity gangrene or wound, so they get debrided, they get clean before we do our reconstruction. The hair removal has been shown in multiple studies. Avoid the contact between the graft and the skin. If you guys come to our room, you will see how we drape the patient, and then we cover the legs. We try to protect the graft from the skin, even that is clean and prepped. We try to avoid concomitant procedures, so we do not do amputations of the toes with reconstructions. We give prophylactic antibiotic. We add antibiotic solutions to our irrigations. We sometimes leave them behind in the patient, and of course, the sterile technique. The recommended prophylaxis is what we know for many years, is the CDC recommendation. Cefazolin is the #1 drug. For 24 hours, if we do an open intervention, if it's endovascular, a single dose is enough. If there is a reintervention, we add a gram of vancomycin for the possible colonization of the wound that has been latent over there. And if the patient is known with MRSA colonization, we also add the vancomycin. If we cannot give penicillins, we can give clindamycin, and there is other options can substitute cephalosporins or penicillins. Diagnosis is a history and physical, signs and symptoms of infection, WBC, white count elevation, and vascular imaging. Honestly, as a vascular surgeon, we feel it. We have that instinct that something is wrong with the patient, and sometimes we try to delay it, give them antibiotics. We do all what we can to avoid bringing this patient back to surgery, and that's what most of the times produce catastrophic events. So our preferred method of diagnosis is the CAT scan with IV contrast, provide us with extension, localization, and anatomy for reconstruction. It's a great test. It's very fast, takes only a few minutes, is reliable, and is usually interpreted by us. We don't wait for the radiologist to give us the result. In this ultrasound that I took from the internet, we can see some air and fluid around the graft. Let me see, what is that? Do you have it in Spanish? Well, you know, it's where the arrows are. Ultrasounds, that's fine, thank you. Is that in Spanish?
You don't know Spanish, you're from Iowa.
So you can see some fluid, some air pockets around the graft. Thank you so much, Robert. Ultrasound is limited to extracavitary graft. We are using more often ultrasounds for abdominal graft, but it's more for endograft and endoleaks and size of the sacs, but we don't use it really for diagnosis of infection. However, I'm sure that once in a while we do an ultrasound, we see fluid around the graft that is very suspicious. It's very limited to the operator experience. You know, ultrasounds, and we read thousands of these every year in this hospital. Depends on who is doing it, better quality, less quality, the window of the patient, so it's very important. What we look for in the ultrasound is the presence, #1, of flow into the graft. There is fluid, the presence of disruption of the anastomosis, hematoma, or soft masses around the graft. Many years ago, or a few years ago, they tried to get more fancy in the diagnosis of something that is relatively simple. You know when the graft is infected, you feel it, the HMP is very clear. But you know, people started with MRI and white blood cell scan. So it was a study, retrospective study. They did WBC scans and MRIs. 35 patients of the patient studies came back with reported graft infection, surgically excised, cultures positive. What we learned from this study is that MRI is superior to WBC scan. It's very good, it's very accurate, good prediction of the infection and extension. The WBC scan is better for late graft. Accuracy is only 80%. They said they delineate the graft extension, but none of us will reconstruct a patient based on this scan. Endoscopy is used only when the patient has some kind of communication between the enteric system and an artery, or urological procedures. Arteriography, that is our standard care for diagnosis of peripheral arterial disease. It's a good tool for graft infection, does not provide you extension, does not provide us with localization, but can show some of the complications secondary to the graft infection, like disruption of the anastomosis, and provide us also with a map that will allow us to do the reconstruction for these patients. The reality is that most of the time, exploration, excision, and culture of the graft is the best diagnostic test for this condition. So most of the time when we are suspicious of the graft infection, we go for it and we try to remove it if it's possible. So let's go to the nightmare part of this. We learn where it's coming from, the pathology. So once we have diagnosed this patient with graft infection, we have to find out if these patients are stable or not to go for surgery. Not always is possible. If the patient is a late graft infection, we have a chance to optimize the patient with TPN if they are malnourished, antibiotic therapy, whatever we have to do to improve the patient's condition. We can start asking ourselves, where is the graft infection, where it starts, where it ends, what I'm going to do to fix it. So there is few options when the graft is infected. We try to do graft preservation. That's what most of us try to do it. We can do a graft excision without revascularization if possible, revascularization with graft excision, or graft replacement inside. For graft preservation, there is few criteria in terms of when we can do it. So number one, the graft has to be patent, cannot be made from Dacron. In multiple studies have shown that Dacron is way more sensitive or more prone to infection. When they get an infection, it's way more difficult to remove it. Some of the bacteria produce this glycocalyx that acts like a glue and goes into the interstitium of the graft, and that makes the graft basically cannot be preserved. The anastomosis should be intact, and most of the people will prefer that the anastomosis is not visible in the reconstruction, and the patient cannot be septic. We do aggressive wound care, debridement, open, antibiotic beads, systemic antibiotics, wound coverage, vac dressings, anything that we do to preserve this graft when it's possible. If we have to replace or we have to substitute or revascularize a patient, we have multiple options. We have autogenous vein graft, that's our number one option, biological graft, and prosthesis. We talk about autogenous graft. This is the list of veins that we have available to us. We have the saphenous vein, the laser saphenous vein, the upper extremity veins. We can do a composite, part of the upper extremity with lower extremity. We can do deep femoral vein, radial artery, and left renal vein for larger conduits. Superficial femoral vein and deep femoral vein, they're excellent conduits for reconstruction. They provide with excellent reconstruction for aortoiliac tree, very good patency rates, very difficult, and they are difficult and laborious to be harvested, but it's in our arsenal of things that can be used. Biological graft, this is more historical than something that we use routinely, umbilical vein. For the ones that, in the early 2000s, we were through fellowship. We all met Dr. Dardick, who's still an active vascular surgeon in New Jersey. He was the owner of the company, and he promoted this vein a lot. However, the vein failed almost every trial. A lot of aneurysmal disease. The patency rates were very low, but it was used when the patients needed this kind of reconstruction for graft infections, and he used it routinely in his cases. But now this historical, we don't have it. I don't even know that it's available, umbilical vein. I've never seen umbilical vein available. Cryopreserved veins, we have them here, very expensive, very nice. They look phenomenal. When you take them from the package, they look beautiful. But in reality, they have a very early failure rate, a high rate of 17%, at 1 year, 80%, at 2 years, 42%. When a miracle happens and after 2 years, they're still open, 33% will degenerate into an aneurysm. So it's really something very short used, and usually the patients end up with a limb loss. If we have to use prosthesis, we have PTFE and Dacron. Can be done with or without heparin, and with and without antibacterial coat. So talking about lower extremities, let me bring you what is the difference of using each one of the conduits. And as we see, autogenous conduits are much better than prosthesis, and you can see the patency rates, how through the years goes lower when it's synthetic. Below the knee is even more prominent. A below the knee bypass done with PTFE has it's a 40% at 5 years. When done with vein, is 77%. So autogenous is usually the way to go when we can. Even when there is no graft infection, that's our first option. So we decided to take the patient to the OR. We have to find out if the patient will go for revascularization. If the patient will go for revascularization, how are we going to do it, anatomic or extra-anatomic? Are we going to excise the graft at the same time? Are we going to do it later? Are we going to debride the wound? How much of the graft we're going to take? And which kind of antibiotic therapy we're going to provide to the patient? In thoracic aorta, we usually go with in situ replacement. We impregnated the graft with rifampin. We put local antibiotic irrigation. We do graft coverage using pericardial fat, rectus abdominal, latissimus dorsi, greater omentum, whatever we can do to protect that graft from infection and to provide more circulation so the antibiotics get there easier. Aortoiliac graft infections are a little bit more generous in terms of how we can reconstruct them. So the classic teaching is to do an AK Fem bypass first and then excise it 24 hours later. In our practice, usually we do the AK Fem and excise at the same time. Usually it's because we have an extra pair of hands that make the time of operation much shorter. The mortality for a graft, in aortoiliac graft infection is around 13%, amputation rate of 1%, late amputation 10% after the limbs fail. We used to use a lot of cryopreserved aortic graft, also very expensive, very nice. It's very nice to suture a cadaveric aorta into a patient. It feels very good. You feel that it's very resistant to infection, but in fact, there is a 5 to 6% of reinfection and rupture incidence. In situ replacement is what most of us are doing if there is no gross infection. It's more of a late infection. We do like we do in the chest. We impregnate the graft with antibiotic therapy, with antibiotic rifampin, and then we do an in situ replacement. This carries a mortality of 4% and amputation rate of 3%. Let's talk about the extra-anatomic bypasses. The patency rates and how we choose one to another. The best way of reconstructing extra-anatomically aortoiliac will be using a descending aorta to femoral artery bypass. It's a long tunnel. It's a difficult operation. Many times we have to put the patient in one of those awkward positions where we have to invade the groins and the chest at the same time, but it's most likely one of the best ways to reconstruct. The axillounifemoral bypass, we try to avoid them as the patency rates are very low. The axillobifemoral bypass has a much better patency rate. The transiliac lateral bypass, I never done one. Hopefully one day I will do one. Lateral femoral bypasses, very well described, and the Fem-Fem bypass as well, when we have only one limb of the iliac limb to be infected or involved. Obturator bypasses, it's more of a teaching bypass. I guess I'm sure that some of my more senior partners have done in their practice. I never done one outside the fellowship. It's a very deep tunnel, go through the obturator membrane. We have to be very careful when we do the operation not to get through the vessels. So there is a technique on where to tunnel the graft, usually anterior and medial. Otherwise, we're going to have to open the patient and resolve the bleeding. So these are the options that we have if we have to remove or we have to have a reconstruction of the groin. We can do lateral femoral bypasses. We can do transiliac. Basically, I don't know how we're going to make aorta to come to the room and open a hole in the iliac bone. Crossover bypasses, obturator bypasses, Fem-Fem bypasses. We have multiple options to reconstruct it. Basically, we have to bring blood from one side to another one way or another. I bring this slide is because I was tortured by my attending. Dr. Padberg was my attending in fellowship, and every problem at the knee or at the groin was resolved with a lateral approach of the above the knee popliteal artery. So it's just more to remind me the pain of fellowship than really what we do. So it is a very difficult exposure. He used to say that was very easy, and he described it as a very easy reconstruction. When I was a fellow and asked him, so how you did the reconstruction? Did you do it in a patient? No, he did it in cadavers, and he did like 2 or 3 in patients. So it's not something that we routinely. This is the photo of Dr. Padberg, just memories. So infrainguinal infections. We always try to do graft preservation if we can. That's our goal. We know that if we don't do graft preservation, the reconstruction that we provide in the patient has less patency rates, and we're going one way or another to lose the limb at some point. We go very aggressive. We do a very aggressive debridement of the area. I particularly use antibiotic beads. I do the antibiotic beads in the back table. I use vancomycin for them. I was talking to some of the infectious disease and ortho, they are adding gentamicin to them. I've never done it, but it's not the kind of bacteria that is usually in our infections. Flap coverage, we like to cover the graft with something else. So usually I use Sartorius muscle flap is what we usually use. It's the easiest one to use. It's in the groin, easy to detach, and easy to place. Rectus femoris flap is the second one. It's a much better flap, and we're going to see the studies. However, it's more difficult to harvest, and it's more bulky in the thigh. Many times we have to call plastic surgery to come and help us. VAC therapy to decrease the fluid and the inflammatory process. We try to excise the entire graft when we can, with or without revascularization. And if we cannot revascularize, many times patient end up with an amputation. So the groin is our most common infection area in vascular surgery. Why is this happening to us? Infected lymphatic tissue from the wounds in the lower extremities is an area that is very close to the perineum, is very superficial. The grafts are very superficial. Even in the very big patients with big BMIs, the graft still very superficial compared with an intracavitary graft. The incidence around 5%, and we try to do very aggressive antibiotic therapy and wound care. Groin infection and VAC, it works, has been shown in multiple trials. We use it routinely. We're going from the open wound infection VAC now to the closed wound VACs, where the incision is closed, and we put a suctioning system on top of them just to avoid the fluid accumulation and to increase and promote wound healing. We use muscle flaps because we want to improve leukocyte function and oxygen tension in the area of infection. It works very good. It's relatively simple. There is 3 options at the level of the groin. We can use Sartorius, Rectus, and Gracillis. I never done a Gracillis, and I think none of us has done it before. Sartorius muscle flap is the easy one to be performed. However, the circulation of the sartorial muscle is a little bit more complex than the rectus femoris, so we have more flaps that fail compared with the rectus. As the rectus femoris muscle is irrigated by profunda femoral artery branches, has much better irrigation and usually lasts longer than the Sartorius. Gracillis is just to mention that it's done by some people, but I never done it. I have no experience with this. When we talk about supraortic infections, we get into another kind of problems, because we are not losing a leg, we're not losing an arm, or we're not losing a piece of bowel, or we may lose the brain, so we have a risk of stroke. And the principles of graft preservation and the graft reconstructions are very similar. So we can do many extra-anatomic bypasses in the supra-aortic tree. We can do carotid bypasses, we can do subclavian, we can do carotid subclavians, we can do all these kinds of transposition in the chest, bringing it up to the neck or arms that allow us to remain perfuse our end organ, that is the brain of the upper extremities. So this is our conclusion. Basically, this is a terrible complication that as vascular surgeons we see every day. It's our nightmare, takes hours of our sleep. We try to prevent it using prophylactic antibiotic. We know that work. That doesn't mean we don't need more trials about it. We know that if we use an endograft or we use an open intervention, the antibiotic therapy could be a little bit different. We know that when we do endovascular therapy or open therapy, given antibiotics for more than 24 hours does not make a difference in terms of changing or prognosis of an infection. However, makes us feel very well when we give a prescription for Keflex. Rifampin Boden graft has shown reduction of late graft infections, but not early graft infections. Suction wound drainage in the groins did show questionable benefit. Has not been randomized, controlled, double-blinded, but we believe that is making a difference. The preoperative bathing with iodine or chlorhexidine makes a difference. The glove changes when we manipulate different grafts in the same field, or re-prepping the patient really makes a difference. Even we sometimes change the instrumentation. We try to optimize these patients as much as we can. We try to control their diabetes, their malnutrition. If they have CHF and edema, we try to de-risk these patients. If they have other sources of infections, we want to control them. We want to resolve them before we go for these operations. Preoperative antibiotics, antiseptics, bioocclusive drapes, we use them routinely. That has not shown any benefit, but looks very nice when we prep and drape these patients and makes us feel much better. There is some of them that come with iodine that we believe makes a difference, but nobody has shown a difference. Has other methods like ultra clean OR airflow, like they use in ortho, the space suits and everything, has been question, but we don't use them in regular basis. The most important is the appropriate wound care, and of course, the removal of operative site using a clipper and not a razor. So this is our nightmare. Thank you so much for coming.
David, great review. Could you comment a little bit? We have a new iatrogenic disease process. It's called infection of closure devices, which we use in the cath lab after a PCI, after a TAVR, after diagnostic cath in an effort to, quote, decrease length of stay, decrease discomfort for our patients, where we're really leaving, depending on what closure device, anything from a suture to a biodegradable piece of plastic, et cetera, collagen. And fortunately, we don't see a whole lot of infections here, but when we do, it's pretty devastating. In other words, we've taken a benign condition, hold pressure for 20 minutes and let the patients home in 4 hours, and now we're getting them up in 20 minutes using the closure device, and if they get infected, because again, our sterile technique is pretty good, but it's not, we're not really in an OR. We're percutaneous, so we're going through the skin, et cetera. Could you comment on that? Yeah. And I know you've seen some of them, none of mine, of course, but you've seen some.
So definitely closure devices are challenging in terms of wound infections. It's not frequent, it's very infrequent. Their data is very good when you go through the MINGS website, and I have to review it recently for a case. All those companies, their data is very good, very low chance of graft infection, infection of the plug. One of the things that we do in vascular is we do an incision at the level of the groin, very small incision, just to be sure that that plug goes deep, and there is nothing trapped in that tract. I guess using a suture like a perclose is better than using a plug, that will take more time to infect. I think it's very operator dependent. It's the expertise of the operator. I don't use MIGS because, I'm not an expert, but I use percloses left and right with no problems. But, it's very infrequent. I can tell you that we don't see that often as before. Yeah.
Thank you. Wonderful presentation. So I'm a cardiac electrophysiologist, and we implant permanent devices, which also the bane of our existence is when they get infected. And in the device world, pacemakers, defibrillators, there has been a increasing use of special pockets,
the revamping pocket,
and where we essentially put the patients who have the highest risk, which usually are redos or people who are diabetic and very obese, and, renal insufficiency. We literally wrap the device in an envelope, and over time it just degrades on its own. And it has been demonstrated to decrease infection. I wonder if something of that nature around, just placed around your graft may be of help, and has that been looked at, or is there an opportunity to perhaps partner with industry to see if that might help decrease the risk of
they sell
infection?
grafts that are impregnated with antibiotics or sulfa. We do a solution of rifampin in the back table, and we impregnate the graft when we know we're going to go into an area that is a high risk for infection or it's coming from an infection area. So we impregnate the graft. There are grafts that impregnate better than others. PTFE, Teflon does not impregnate as good as Dacron. So now there is a combination of Dacron and PTFE. I think that's a good solution where the Dacron is outside the PTFE and that will impregnate. So we don't wrap the whole graft. Our grafts sometimes are very big, so it's difficult for us to wrap them. We more use tissue of the patient to wrap them, omentum, fat, whatever we can find, muscle, and antibiotic bits, that's what I use. But yeah, we try to impregnate the graft when we can with antibiotics.
Thank you, David, for an excellent presentation. Two questions. Since the practice of vascular surgery has changed so much for more invasive procedures over the past several years, have you noticed any difference, especially for thoracic and abdominal aorta, in the rate of infection, open versus endografts? Question number one. And question number 2, how do you treat the infection of the endografts?
So
Challenging question there.
yeah. So I guess, that I don't think there has been change in the chance of infection. It's still 0.2 to 1% endograft infection. If chest or belly must be the same. We don't see many of them here. Most of them, we see them coming back from other centers to us. Endograft infection is once they're infected, it's very hard to preserve. So those patients, we do in situ replacement or extra-anatomic with excision of the graft. I cannot remember the last one that was not done. Well, we have one recently, one of my partners have one, but the patient is not a candidate for reconstruction. So the reconstruction will be so complex that the patient cannot go for surgery. Will be a full mesenteric reconstruction plus the iliacs. So a patient has a low EF, around 20%. So it will not happen. That patient will not go for surgery. And that patient is with antibiotic therapy and basically hospice.
Great lecture,
Thank
David, and it's something that since, as Jorge alluded to, has changed so much, and I think we've changed a lot of things preventatively that we do, which leads to my 2 questions. One, we've grown up with surgical dogma of this irrigating a non-contaminated wound with antibiotics, and as we all know, they act systemically, not on contact. Otherwise, we'd all shower with antibiotics every day. Yeah. But I think that there's no data really to demonstrate any efficacy of that. In fact, I've never irrigated a non-contaminated wound with saline or antibiotics. Back in general surgery days, I was at MD Anderson, said, why would you want to wash out all of those white cells and all that good stuff that the body's made to do that? So one, I want to, is there any surgical data that demonstrates, or any data that demonstrates the efficacy of that? I know impregnating some grafts really is never shown and all these are retrospective trials or surgical dogma, no randomized trials, which of course would take 10,000, 30,000 patients. So that's one. And if you want to comment on that, and then I'll ask.
Yeah, the evidence level for antibiotic irrigation in the wounds, it's basically minimal. It's a very low level of evidence. Has not been proved to be real. I agree with you. I don't irrigate my wounds much. I mean, I just go, and it's very funny because my PA or my PS when work with me, they have a tendency of cleaning and irrigating. Say, you don't have to. I mean, I just remove basically what is the debris with a 4x4, remove what is not attached to the patient, and then I close it. Non-contaminated wounds. I'm talking about, and so I do the same as you. I mean, I'm not a big irrigator for my groins or for my legs. I don't do much of irrigation. Antibiotics and graft. No one has done a randomized control trial, blind, that does not exist. I don't think it's going to happen. It's more retrospective cohorts, people who has the experience of Bandic did in Tampa. He proclaimed himself as an expert on graft infections, and we believe that he was a graft infection. I mean, the guy really published and knew about it much more than all of us, and that's what we're based on, experiences. That's what, to be honest, that's what it is. The level of evidence is very low.
Because there's no science behind it. Now that we're using even 3rd and 4th generation cephalosporins to irrigate, just the economic impact of that, I think, is something that we need to be cognizant of.
I know you remember, but a few years ago we had antibiotic-coated permacath. Mm-hmm. And as they came in very fast, they left very fast because there was not a difference. Mm-hmm. So they were silver-coated and chlorhexidine in the outside, and it didn't work. So I agree with you.
We did all that with valves, and there was
and you did it with, correct.
Behind there. The second question is, you mentioned the patency of grafts when you put them in an infected wound, but you didn't mention very much the reinfectivity of those grafts. And again, back to general surgery with people shot and stabbed in a contaminated wound, you throw in a piece of Gore-Tex, and they very rarely got infected. Yeah. So I just, is there any data on
yes.
on some of the secondary operations on what is your least likely graft or conduit to get reinfected? But thank you again. It's very helpful.
I mean, if we want to really minimize reinfection, it's to avoid the area of the infection. I mean, an extra-anatomic bypass, go around the area of infection in the groin. We go lateral, we go medial, obturator, whatever we have to do. If it's abdominal, acts by FEM. But there is places that we cannot do that. I mean, when you are in a supraortic vessels, you need to bring it somehow. So you have to do an incisal. There is a reinfection rate of around 3 to 4%, regardless of what we do. And if we use Dacron, they think it's a little bit higher, but when you go to the vascular meetings, they will say that if you soak them in rifampin, goes lower. But it's also, single institutions, their experience, their cohort, what they're doing. So it is hard to. I don't want to give you information that is not real or sustainable. But it is present. It's around 3 to 4% reinfection rate, even on the best circumstances. So I don't these patients.
Trials really to define.
Yes.
I was there with Crawford.
Yeah.
Pacelli were doing the antibiotics.
Yes.
Grafts. And, they did it. And said, well, I think our infection rate's lower, which is all retrospective.
So when I was a fellow in New Jersey, Dr. Vieth used to come to our meetings, and he's like nowadays a little god that we have. Whatever he says, we follow. And so one of my attendings, he came to talk to us about rupture AAAs. And one of my attendings was very into studies. He was a guy doing the studies. And he asked, that he wanted Vieth to do a retrospective randomized double-blind controlled trial in rupture AAAs open versus endovascular repair. And his answer was, I still remember, I remember he mentioned the name of the attending. He said, I'm going to randomize that, and I'm going to randomize also people who jumped from a plane with and without parachute. And he was telling me, that what he tried to tell us is that we cannot randomize this patient, we cannot do studies on this patient because they're so difficult. And you guys see them when you guys have a graft infection or a valve infection, is a nightmare. I mean, it's like you don't want to leave the hospital. You don't want to come. You have it on Monday. Sunday, you are sweating. It's coming on tomorrow. So it's for all of us. It's hard, but for us in vascular to do these kind of studies will be very difficult. In other grafts that are not, that where the end organ is not that important, or there is not an organ like dialysis graft, I'm sure that we can do that. Because if you remove the dialysis graft, you put a catheter someplace and you can do it and you can study those patients. But when we're talking about limbs, brains, carotid, it's a little bit more difficult for us, for you, for valves. I mean, I don't know. Well, in the preoperative? Oh, no, I don't. Yeah. Yeah. Yeah, it is.
Let me challenge you a little bit, because I noticed that you did not. I noticed that you did not include aortocameral fistulas, aortoenteric fistulas, and I'm just wondering when you have somebody who has a suspected aortoenteric or aortocameral into the left atrium or somewhere else, does that change your approach to patients like this? Because I suppose they can rupture and die very quickly. And so I think these are actually as challenging as what you described over here.
Yeah. The patients with an aortoenteric fistula, usually they present with a sentinel bleed first. Usually that's what happens. They have a sentinel bleed, they have a very significant GI bleed, and then they stop, they tamponate themselves. And during endoscopies, when they found in the fourth portion of the duodenum, that ulceration, and with the patient has a history of reconstruction before. What I did in training, and I don't do it here anymore, is when I have those cases that usually happen Sundays afternoon, I go for an X by Fem first, and then we excise the graft, if there is any, and usually there is. And the duodenum reconstruction, I used to do them. I used to exclude the duodenums and put a mushroom tube in the duodenum, but here we have general surgery, so they try to do their best. It's a very challenging, I don't know how you guys do with the chambers, fistulas, I've never done one.
Well, I think that since you have the expertise in this is something that it would be in your best interest to know how to do, and perhaps you could even do it better than anyone else. What about esophageal perforations from a graft?
Esophageal perforation, if the patient is unstable, usually we will try to put an endograft first to stabilize the patient.
In the face of infection?
Yeah. I mean, if the patient is unstable, is actively bleeding, is unstable, you put an endograft, stabilize the patient, and you know that endograft is coming out. And most of the times, if you don't remove the endograft, you know that it's going to come back with some empyema or sepsis or something. So it's better to be proactive. You know that that's just a temporary measure to control the bleeding and this situation.
Well said. Well said. Thank you for those answers. Are there any other questions? Well, thank you, Dr. Varnagy, for a most compelling and interesting grand rounds. We appreciate it.